So this presentation is about the quality improvement dissertation. It's the last module on the MSc Advanced Clinical Practice programme at the Faculty of Nursing, Midwifery and Palliative Care at King's. I am the module lead for that dissertation module, and I'm going to tell you about the nature of the module and the assessment for it, and the application of sustainability content within the student projects. My co-presenter is Harry Simmonds. He's a former student of the module, and he's going to outline the project that he did and will introduce his role later on. The students on the quality improvement dissertation come from a variety of professional healthcare backgrounds. These include nursing, pharmacy, paramedic science, as noted here. For the module assessment, they are required to conduct a quality improvement project in their own clinical organisation. The Centre for Sustainable Healthcare SusQI workshop is embedded within the timetable and is based on the educator pack. Sustainability is featured in the module aims, the learning outcomes and the marking rubric, and we're currently examining 5 years of student projects to evaluate how that education for sustainability has been applied in the students' work. Yes, so if you go to the second one, so this is the one that talks about that the module and the nature of the assessment and the fact that the sustainability is embedded within the learning outcomes, etc., and our 5-year evaluation of the student projects. Next one, please. So this slide presents the data showing the number of students in each of the last 5 cohorts who have demonstrated use of a SusQI design in their project. Cohort numbers are represented in the brackets. It should be noted that the 1920 cohort didn't have the workshop. This was before we had the pilot with the Centre for Sustainable Healthcare, but they're going to serve as a control in many ways. The 2021 cohort didn't have the workshop embedded. Their projects were affected by COVID, but they were invited to attend the workshop for the following cohorts, and the workshop has been run in all subsequent cohorts. The dark green bars show the number of students who specifically applied the SusQI learning in their project design, and you can see that that's increased in later years. The light green bars represent the percentage of students using the design per cohort to allow cross-cohort comparison. It shows a higher percentage of students using the design in the 2023 cohort, although they are still relatively low percentages given the cohort sizes. However, many of the students, not specifically stating use of this design, still described elements of their projects that would align to the triple bottom line. I'm now going to hand over to Harry. So next slide, please.
Next slide, thanks. Hi, my name's Harry Simmonds. I completed the ACP Masters in 2023. I work as the Deputy Lead Nurse in the Camden Rapid Access Service, which is in inner London, and we support patients to stay at home and avoid admission when safe to do so. At the time of starting the QI dissertation, we'd undertaken an audit within the team which identified that the number of unnecessary admissions instigated by the team's clinicians had increased over a 2-month period. We considered this to be a problem, as although some patients do, of course, need to be in hospital, upon review, a lot of these patients, a lot of them were unnecessary admissions. And as we know, unnecessary hospital admissions significantly affect the triple bottom line, affecting patients physically and psychologically, causing financial strain and unrequired resource use. Next slide, thanks. So a quality improvement project was undertaken to decrease the number of unnecessary admissions instigated by our staff, and to achieve the aim, objectives were set to decrease variation in decision-making across the team, improve the escalation process, and improve clinical communication between team members. Another objective part of that was to improve the escalation process within the team, and we did that through reviewing the team's understanding of the News 2 score and how we utilised it within the team, and updating our processes. Another objective was to improve clinical communication between team members, which had been identified as challenging at times due to the nature of lone working, and how busy the nurse in charge role could be, and the sort of decreased ability that they had to liaise and talk with the clinicians on the ground, seeing patients within their houses. We used different stakeholder engagement opportunities to bring a diverse range of perspectives to support the development of the project. We'd use cause and effect diagrams to start to consider the underlying causes of the problem of increased hospital admissions, as well as the 5 whys root cause analysis to dig down further to the root cause of the issue. So some of these included, as I said, the escalation process could be more straightforward. The complexity of patients required in-depth planning and thinking to keep them at home safely, time constraints on senior clinicians being called who were not available to talk at that point in time. So we developed this driver diagram, which was developed by the project group to graphically represent the theory of change for the QI project. So next page, thank you. So we utilised the 4 priorities of sustainability in healthcare as our primary drivers, and the chosen objectives and change ideas aligned with the 3rd principle of sustainable healthcare, lean service delivery, as this offered the most significant impact of change with the time and resources that we had available. Next slide, thanks. So a value process map of the UCR pathway was created and analysed to inform the decision of where to fit the change intervention into the process that would add the maximum value to the triple bottom line. And next slide. So the top of the process we analysed as having showed the lower resource use, and this was looking at environmental, social and financial impact. Next slide. Well, the lower section highlighted the higher resource use, and this was particularly once a call had been made by our team members through to the ambulance service and to start that sort of cascade of escalation. So next slide. It was decided that the maximum value could be created by incorporating a change idea prior to a call being placed to the ambulance team by our team member, so in that target zone of where the blue circle is. Next slide. So a mixed methodology quality improvement project was adopted to design and implement an escalation phone line to make shared clinical decision making between team members easier. The sustainability in healthcare QI framework was used to ensure value was added to the triple bottom line, and plan, do, study, act cycles were used to introduce iterative change. 2 focus groups were conducted to get feedback on the experiences of the UCR clinicians who use the escalation line on a day-to-day basis. We went through a process of 4 PDSA cycles during the time I was running the project, and we were able to use another key principle of sustainability when setting up the phone line, which was reusing and recycling and eliminating waste, as the phone line that we did ultimately use was already being paid for, was already in place, but just wasn't being used at all. Next slide, thank you. So overall, a decrease in the average of unnecessary admissions instigated by the UCR pathway was seen from 5 patients a week to 2 patients a week. And correspondingly, the percentage of patients that we were sending to hospital and who were being admitted to a ward, which we deemed as necessary admissions, increased from 60 to 82%. So indicating that hospital admissions was the correct decision for these patients rather. Next slide. So by creating an opportunity for staff to communicate with senior clinicians while at the patient's bedside in the patient's house, this allowed for quicker access to shared clinical decision making, and the amount of unnecessary hospital admissions instigated by our team was decreased. This resulted in a reduction of 150 kilograms CO2 equivalent per week, social improvement of improving communication and trust within our team, as well as financial savings of the cost of an ambulance and a visit to A&E, which was roughly £700 each time.
Next slide, please. Thank you. Thanks, Harry. And this is our final reflections. We feel that the quality improvement dissertation gives the ACP students an opportunity to address clinical issues in their services through a supportive supervised assessment work. The QI project assessment work aligns well with the sustainability agenda and the triple bottom line. Embedding the workshop in the timetable raised awareness in the students and motivated many to discuss climate issues for their specific projects, whether or not they actually used a SusQI design. The advanced clinical practitioner role is well placed to manage this service change in terms of reduction of resource use and waste, illness prevention, and through streamlining processes. And to that end, we think that the ACP role, it should include a sustainability focus, and it could be much more strongly supported in healthcare policy. That's us, Aoma. Thank you for helping.